If you've ever stood in an intensive care unit, you know the mechanical ventilator looks, well, like an incredibly complex, terrifying machine. In this explainer, we're going to change that. We're going to totally demystify mechanical ventilation, transforming this intimidating box of alarms and tubes into a highly logical, step-by-step physiological tool. By the time we finish up, you'll see exactly how clinicians use this life support technology to give failing lungs a real chance to heal. It all comes down to this fundamental, incredibly high-stakes question that we have to answer every single time we intubate a patient. How do you breathe for someone who can't, without actually damaging their lungs in the process? We're constantly navigating this super delicate balance between saving a life with positive pressure and, unfortunately, causing ventilator-induced harm. So here's our mental roadmap for the patient's journey today. We'll start with why we ventilate, then move through mastering core settings, fine-tuning the breath, exploring the true power of PEEP, and finally, navigating complications and the weaning process. All right, let's dive right into part one, why we ventilate. When we talk about general indications for intubation, we're really talking about extreme physiological failure. Things like severe hypercarbic respiratory failure, where the body just can't clear carbon dioxide, or refractory hypoxemia, where oxygen levels plummet despite our absolute best non-invasive efforts. Or it could simply be a patient's inability to protect their airway and clear secretions. Now, when a clinician approaches the bed to address this, they don't just guess. They follow an actionable, highly structured checklist, kind of like an ED ventilator protocol. The goal here is rapid stabilization. They'll obtain an accurate height, set a tidal volume based on ideal body weight, set PEEP to at least 5 centimeters of water, and initiate oxygen. Actually, following these exact steps is absolutely crucial to prevent initial volume trauma, which is lung overexpansion, and hyperoxia, right from the very first breath. Okay, moving on to part two, mastering core settings to ensure safe lung protection. Once the patient is actually connected to the machine, our immediate priority shifts. Listen, if there's literally one number you take away from this explainer, it is this: 6 milliliters per kilogram. You've got to permanently anchor this rule of 6 in your mind. Limiting the tidal volume, which is the size of each breath, to roughly 6 milliliters per kilogram of ideal body weight is one of the most critical fundamental ways we prevent lung injury. We're essentially trying to mimic the natural physiological breath size of all mammalian species. And that emphasis on ideal body weight, it is absolutely paramount. To see how the 6 mL/kilogram rule is applied in practice, clinicians rely on standard conversion charts. Tidal volume is dictated strictly by the patient's height and their predicted body weight, not their actual weight. Think about it. A patient's lungs don't suddenly grow larger just because they gain weight, right? So we literally use a tape measure to get their height, consult the chart, and dial in the precise protective volume to avoid stretching that delicate lung tissue. Everything we do from here on out operates on what we call the Goldilocks principle. We have to constantly balance the extremes. If we give way too much volume, we cause pressure damage. But if we give too little, the lungs collapse and oxygen drops. It's a constant game of fine-tuning, ensuring the ventilator settings are neither too aggressive nor too passive, but, just right for that specific patient's current lung compliance. That brings us to part 3, fine-tuning the breath to optimize delivery. Bridging those abstract numbers we just talked about to the actual ICU monitor, the volume assist/control interface really acts like the cockpit of the ventilator. This is where the true art of mechanical ventilation begins. We're adjusting the delivery of air based on the patient's real-time lung mechanics. Clinicians will input empirical settings here to optimize oxygen transfer. For example, parameters like the inspiratory time, which is usually set between 0.6 to 1.2 seconds, dictate exactly how long the machine takes to deliver that calculated tidal volume. You'll also notice that modern ventilators use these really distinctive decelerating flow waveforms. Instead of delivering a square, constant blast of air, the flow starts high and tapers off. Why does this matter? Well, this decelerating pattern is generally way better tolerated by the patient. In fact, it's the default choice for a lot of intensivists because it promotes patient ventilator synchrony and significantly improves gas distribution. When we switch gears to pressure-controlled ventilation, we can visualize even more advanced nuances. Take the setting for rise time, for example. This dictates exactly how fast the ventilator reaches its target pressure. We actually have to manipulate this to decrease the work of breathing. So a patient with an obstructive lung disease like COPD needs a totally different rise time compared to a patient with a restrictive lung disease like ARDS, just to ensure they aren't actively fighting the machine. Next up, part 4, the power of PEEP and its crucial role in alveolar recruitment. PEEP, which stands for positive end expiratory pressure, is a notoriously powerful setting in intensive care. Imagine the alveoli, those tiny air sacs in the lungs, like a delicate honeycomb. This perfectly illustrates our Goldilocks motif at the microscopic level. Too little PEEP causes dangerous cyclic alveolar collapse, known as atelectasis trauma. Basically, the sacs snap shut and violently rip open with every single breath. But on the flip side, too much PEEP results in shearing stress, alveolar rupture, and barotrauma. We use PEEP to keep those honeycombs propped open just perfectly.
But here's the catch. PEEP is definitely not a magic one-size-fits-all solution. You have to constantly weigh its beneficial effects, like recruiting damaged non-aerated lung tissue and improving oxygenation, against some pretty severe, harmful hemodynamic consequences. Because PEEP increases pressure inside the chest, it literally squeezes the heart. This can lead to a massive reduction in venous return, severe hypotension, and an increased afterload on the right ventricle, which can drop cardiac output entirely. It's a real balancing act.
When we compare CT scans of different lung pathologies side by side, it vividly proves why clinical judgment is just so vital here. Different diseases exhibit completely different levels of recruitability. Take COVID-19 phenotypes, for instance. The early L type has spared compliance and really isn't amenable to recruitment, whereas the later H type has diffuse damage that actually does respond to higher PEEP. What this means is that PEEP titration has to be deeply personalized to the exact morphology of the patient's specific lung injury. Finally, we reach our exit strategy in part 5, complications and weaning.
Getting a patient onto a ventilator is really only half the battle. Getting them safely off of it requires incredible clinical mastery. First and foremost, your ventilator is only as safe as your alarm settings. Believe me, this isn't just background noise. These alarms act as a vital safety net to immediately detect life-threatening events. By setting strict boundaries in our parameter guidelines for low and high inspiratory pressures, minute volume, and respiratory rate, we ensure that the very moment a patient experiences hyperventilation, hypoventilation, or an airway obstruction, the clinical team is alerted instantly. Because the reality is, you have to remain hypervigilant for secondary injuries. These complications range from simple mechanical issues like tube malposition or kinking to profound invisible cellular damage. For example, biotrauma occurs when alveolar overdistension triggers a massive systemic cytokine release, causing severe inflammation throughout the entire body. The ventilator can totally save the lungs, but if mismanaged, it can damage multiple other organ systems. Once the patient stabilizes and the underlying disease actually improves, you rely on a rigorous daily weaning protocol. You don't just walk up and pull the tube out, right? Instead, you perform spontaneous breathing trials, or SBTs. This means dropping the support down to minimal levels for about 30 minutes and systematically testing if their respiratory muscles, their oxygenation, and their hemodynamics are actually strong enough to take over the massive work of breathing all on their own. Ultimately, mastering mechanical ventilation leaves us contemplating this final, super delicate art, recognizing the exact right moment when the machine has successfully healed the lungs, and it is time for the patient to breathe on their own. Do it too early and they collapse from exhaustion. Do it too late and they suffer from ventilator-induced complications. It is an incredible responsibility. So when you look at those patient monitors next time, ask yourself, are we actually healing the lung today, or are we just buying time?